Let's wait for 5 more minutes for doctors to join and then we can start.
Sure. Hello.
Yes, Dr. Jha. I think let's
Yeah,
wait for five
I'm
minutes
telling
and then.
that I am I think without headphone also I am audible.
Yeah, you're audible.
So let me switch off this.
Sure.
Okay. And let me know whether this PP is visible or not. So I think PPT is also visible.
Yes, it's visible. We can see your presentation.
Oh, very nice. Okay. So it's early morning there.
No, actually, I think it should be
Still
somewhere
daytime.
around 12:30 or 1 o'clock in Africa. It's afternoon.
Okay, after afternoon.
Sunday afternoon, correct.
Okay.
Just checking, give me 5 minutes. I'm just checking if all the people are here who signed up.
Sure. Sure.
Is Jonathan here? Hi, Jonathan, are you there on call? Samir, is Jonathan here? Can you confirm?
Yes, I'm around. Can you hear
Yes.
me?
Yes, Jonathan, we can hear you. So, Dr. Jha, we have a
All right.
translator, Jonathan, here with us. He will help translate everything you say in French for our French-speaking doctors from Congo.
Okay.
So we would request you to probably speak one line, wait for him to translate, and then whatever our French-speaking audience wants to speak to you or interact with you, they'll do it through Jonathan.
Sure.
All
So
right.
so
So I
Mr.
would,
Jonathan, good
yes.
afternoon.
Yes, please.
So I
All right,
would
yes, please. Can you hear me?
welcome everyone to this webinar by Jivo and Artemis Hospital on joint replacement by Dr. Jha. He is chief and head for the orthopedics unit at the Artemis Group of Hospitals in Gurgaon. So you can take forward.
So basically today we had kept joint replacement as a general topic. It's an overview. So we'll not going into very details, which may be technical, and we will keep it
Uh,
simple so that people can understand what is arthritis and how joint replacement works.
Aujourd'hui, basiquement, nous allons nous baser sur le remplacement des articulations. Vu que c'est un peu large, nous n'allons pas entrer dans les détails. Nous allons beaucoup plus nous limiter sur la pose, le remplacement complet de l'articulation et expliquer comment cela marche. Can you hear me?
Yes.
Yes, Jonathan.
Est-ce que vous m'entendez, les francophones?
Sorry.
Y a-t-il un problème d'audition pour le francophone? Je vais juste me rassurer que j'utilise les casques qui sont compatibles. All right, it's okay. They can, looks like they can hear me. Yeah, you can go on, doctor.
Okay. So let me know whenever you want me to begin.
I think so. You can begin now.
Okay. So as I mentioned, the topic is about the overview of joint replacement, and I am Dr. Ramkinkar Jha, as he mentioned, introduced me. And so this is me, and I have special interest in joint replacement as well as ligament reconstruction and arthroscopy. So I am being trained worldwide, many countries, and so topic we are breaking into first arthritis overview and the goals of joint replacements, ways to perform, and outcomes, and few cases if the time permits, and we'll take some question and answer from the audience, and then we conclude. Okay, Mr. Jonathan?
Ok, je suis docteur Jha, comme on m'a dit, on a déjà introduit. Et on va parler aujourd'hui on aura juste un aperçu de remplacement de l'articulation. Il y a quelques points, comme vous pouvez le remarquer. Euh, L'aperçu de la cause, le but, le moyen de procéder, la procédure, le résultat, ainsi que quelques cas. Et à la fin, nous allons conclure avec des exemples. Et s'il y a encore le temps, nous allons prendre quelques questions. Yes, please.
Okay. So once we think about joint disease, we compare with the healthy. So what's a healthy and what is arthritic? We need to understand. Here you can see three representative photos. One is of X-ray of a normal joint, where we see the joint is very the space is maintained, and in arthritic the joint space is reduced. There is a osteophyte formation. There is a deformity there, and if you see in histopathology the same tissues, you will find the left side is the healthy cartilage. It's a very well architecture, and the disease one is dehydrated, disorganized, and if you see the morbid anatomy, the healthy joint looks very glistening, very smooth, as well as if you compare with the arthritic one, it's totally eroded. So that's the cause of pain.
That's a lot of information. Can you go through step by step so I can translate it words?
Okay, so Mr. Jonathan, just I am showing two sets of picture. One is healthy
All right.
and one is the disease. So by just seeing overview, you can make out the difference. Smooth, which is a healthy one, and the rough, which is arthritic. That's
OK. Partant de ces photos, nous allons voir que le problème d'articulaire sont causés par quelques déformations, quelques problèmes. particuliers qu'on pouvait les remarquer dans des photos présentées là. Dans chaque photo, il y a une partie où toute chose va bien avec l'articulation et de l'autre côté, donc à droite, vous allez voir quelques euh, parties endommagées et il y a même des parties qui sont données. Donc la première, déjà, vous allez voir, tout est bien, et tout est smooth. La deuxième photo, il y a un peu quelques espaces, il y a le tache rouge qui explique quelques problèmes que les articulations font face. Et je pense que c'est la même chose avec toutes les photos que l'on a là. Donc, une partie qui est normale et l'autre partie qui est souffrante. Yes, please.
Okay. So if you go down further on the microscopic level, molecular level, there are a lot of events going on, which forms the joint arthritic. Okay. So this is very complex, but we need to understand there is some molecular level also. Some changes happens. Okay.
Oh, ok. Si nous allions un peu dans le sens du physique, nous allons comprendre qu'il y a différents. Doctor, there's noise in the background. A little bit.
Okay.
Ok.
Start.
Oh,
Continue.
si nous allons un peu plus loin, nous allons voir qu'il y a quelques stages de problèmes. Euh, Par exemple, dans cette photo, on parle des pathologies, on parle
So
de
these are the
la
molecular
non-balance des
events.
régulations.
Okay.
La non-balance des régulations, il y a la formation abnormale des MBS, ainsi de suite.
Okay.
Yes.
So just this is overview that there is a transition from healthy joint to arthritic joint, and there's a change in anatomy as well as change in biochemistry. Okay. So
OK.
so
Là, c'est juste un aperçu de la congestion qui existe dans le les articulations qui sont en bonne santé et celles qui sont endommagées qui causent tant d'autres problèmes. Yes, please.
okay. So this arthritis phenomena happens in all Saneval joints, all major joints. I have taken knee joint as a representative one. One joint I have taken as an example to make our audience understanding. Now, there are many etiology by which arthritis develops. Okay, and they're multifactorial um, uh, inputs which make this decision of treatment of osteoarthritis very relevant. As you can see here, multifactorial things. Okay, right from physical inactivity to obesity to dietary to metabolic syndromes, injuries, all these things are relevant in progression of osteoarthritis.
Euh, j'ai pris quelques exemples pour parler de malformations, encore plus de maladies qui peuvent affecter l'articulation. Pour ainsi parler de la cause, il y a beaucoup de facteurs qui entrent en jeu. Il y a, par exemple, on a cité le vieillissement des muscles, on a cité euh, le blessure, on a cité le régime alimentaire et j'en passe. Qui contribue d'ailleurs à la progression, bien euh, empirer la situation de la cause, c'est-à-dire à rendre la situation difficile.
Okay. So once patient comes to us with a joint pain, the first investigation we do is simple X-ray. X-ray. And in case of knee, it's a standing X-ray, AP joint, so that it gives a dynamic picture. So access should be standing.
Quand un patient nous vient avec un problème d'articulation, la première chose que nous faisons, c'est un examen euh, qui va nous permettre d'avoir un aperçu dynamique de de ces articulations. C'est la radiographie que l'on fait en premier pour avoir euh, un aperçu de ces articulations, ce qui se passe réellement. Yes, please.
So we grade in different categories how severe is the joint on X-rays. Like here, this is a universal classification Kalgren's KL grading system we use. We grade it grade 1 to grade 4 as per severity. How much joint mass reduction is there, how much osteophyte formation, deformities are there. So we categorize from grade 1 to grade 4, and that is from mild to severe one.
Euh, euh, voilà un peu ces catégories. Par contre, la radiographie simple que l'on peut faire, ça va nous donner un résultat qui se présente de la manière suivante concernant le vieillissement et l'arthrose. La classification va de niveau 1 au niveau 4. Et cette classification décrit le stage de la maladie, c'est-à-dire la maladie liée à l'articulation, c'est-à-dire cette arthrose. On voit le stage normal, un peu doutant, moyen, modéré et puis sévère. Yes, please.
Okay. So once we have decided there is a osteoarthritis, there is a comprehensive approach to the pain management. Okay. So you can see like these are the different kinds of things which we need to address while treating the osteoarthritis. So we need to take care about the
Yeah.
flexibility, load management, neuromuscular control, muscle strength, and movement efficiency. Okay.
Donc, maintenant, si une fois que nous avons déterminé qu'il s'agit réellement de la force, il y a beaucoup d'éléments que nous prenons en compte pour le traitement de ces derniers. Il y a le contrôle neuromusculaire, il y a la force du muscle, il y a le mouvement, l'efficacité dans le mouvement, il y a la flexibilité, il y a euh, la gestion de charge dans le muscle. Voilà un peu les éléments que l'on prend en compte pour mieux y procéder, pour l'approche que l'on appelle l'approche compréhensive du douleur. Yes, please.
Okay. So now the treatment we have, once we have diagnosed a case to be osteoarthritis or arthritis of joint, so what we have as a treatment? We start with the non-invasive one, then something less invasive, and invasive is the surgery. Okay. So to start with the non-invasive, we have physical therapy. Okay. Different modalities of physiotherapy we start with. Okay.
Donc, maintenant, une fois que nous avions identifié, nous allons procéder au traitement. Nous avons trois types de traitements. Le traitement non invasif, nous avons le traitement moins invasif et puis les traitements invasifs qui est derrière la chirurgie. Nous allons commencer avec le traitement non invasif. La première, c'est le traitement physique,
And
yes,
then
la
a-
physiothérapie.
and then simple medications we start with. Analgesics we start from paracetamol, that is then NSAIDs, and then opioids. In addition, we use topical NSAIDs and some medications to increase the lubrication. Okay, and these are
Euh,
for early osteoarthritis.
donc, là, nous commençons avec il y a du côté pharmaceutique, nous commençons avec euh, le médicament aussi simple que ça. Par exemple, les paracétamol, le médicament non stéroïde, anti-inflammatoire, ainsi de suite. Nous pouvons aller même avec des prescriptions pour aider avec la lubrification de, de muscles pour la bonne application. Yes.
Okay, so coming to next step, in case of moderate arthritis, once patient is not relieved with the simple medications which discussed in last slide, We offer four kinds of injections. One is hyaluronic acid, other is PRP, that is platelet-rich plasma, stem cells, and the fourth category is steroid, each having its own advantage and disadvantage.
Maintenant, nous en venons au traitement invasif qui est non chirurgical. Et là, on va procéder avec des injections plutôt pour le traitement, pour essayer un peu d'atténuer les douleurs. C'est-à-dire, la personne peut avoir des douleurs sévères et c'est dans le but de pouvoir atténuer. On a différents types de médicaments, de injections que l'on peut procéder avec, notamment les HM ainsi que les stéroïdes. Yes. Et pour pour tous ces médicaments, toutes ces injections, euh, il y a il y a toujours eu de side effects, il y a toujours eu de conséquences. Hein. Yeah.
Okay. So once this um, evident that these injections are not helping the patient and patient is having severe arthritis or moderate arthritis, we can offer few invasive procedures. So basically we can categorize into three categories. First is arthroscopy, that is the keyhole surgery. Second is osteotomies, that is, for example, in case of knee, high tibia osteotomy. And the last category of surgery is the replacement, which will talk elaborate way.
Le traitement invasif qui requiert la chirurgie, nous allons devoir procéder, voir s'il y a de douleurs dans le muscle, tous ces symptômes, une fois ils sont présents, nous allons devoir passer à ces trois procédés, c'est-à-dire nous pouvons aller avec l'anthroscopie, nous pouvons aller avec le deuxième ou encore plus ce qu'on appelle le remplacement de d'articulation. Yes, please.
Okay, so first is a keyhole surgery, that is arthroscopy, where we do the debridements, wash out, joint wash outs. We may remove the loose bodies. We may um, do the trimming of the meniscus tear. As you can see in the photograph, you can see there are different intraoperative picture of joint. So right from cleaning to meniscectomy, we also do, if there is some cartilage defect, we can take care of that cartilage defect also. So these are the cartilage procedure.
Euh, ce traitement requiert que l'on puisse attaquer les parties les plus tendres, les parties qui sont en souffrance. C'est-à-dire, on va procéder à régler ces problèmes et on l'appelle beaucoup plus souvent la méthode de fixation des cartilages. Hein. Donc, comme vous pouvez le voir dans la photo, ça consiste à pouvoir créer de vide, c'est-à-dire à retirer le cartilage les cartilages, oui, les cartilages qui posent problème dans l'articulation, ça peut être au niveau du genou et j'en passe.
Okay. It's a
Yes, please.
okay. So it's a daycare procedure. It hardly takes a day and almost 2 to 3 weeks to just recover. So second is, once joint is not much damage or one compartment is involved, like here you can see in x-rays only the medial compartment is involved here. The medial compartment is only involved. But overall, there is only deformity. So we correct the deformity, we change the alignment. So these are called corrective osteotomies. Like in case this is high tibial osteotomy. Okay. So you can see here the alignment is changed and the joint dynamic is also changed. So it creates a like opening of the joint and realignment. Okay. So
Ok.
In this, yeah.
Pour la première procédure, c'est une chirurgie qui ne prend qu'une journée et ça demande peut-être 3 semaines pour que la personne recouvre ses forces. La deuxième consiste à faire le réalignement, puisque là, il s'agirait juste d'un côté qui est endommagé. La personne peut avoir un problème juste euh, d'une articulation et l'autre est en bonne et due forme. Et là, on va procéder au réalignement de muscles, comme vous pouvez le remarquer dans le photo présentée ici.
Okay.
Yes, please.
So that was the second category, that is osteotomies. Now coming to replacements. Here, what I'm showing is a medial joint arthritis. That is medial compartment osteoarthritis. That's only one compartment is involved. So instead of replacing the whole joint, we just replace the medial compartment as here. It is called unicondylar knee replacement. And this is a relatively small surgery as compared to total joint replacement.
Là, c'était ce que on appelle l'osotomie, le deuxième. Le troisième consiste maintenant à remplacer juste la partie qui est endommagée au lieu de pouvoir procéder au remplacement total. Comme vous pouvez le voir dans les trois photos qui vous ont présentées là, il s'agit juste d'une partie de l'articulation qui est en souffrance. Alors, on procède à pouvoir remplacer juste cette partie-là. Yes, please.
Okay. So this was relatively confined to the intermediate or severe osteoarthritis involving only one compartment. Now coming to the total joint replacement. Before going to in detail, let's see what is the goal of total joint replacement.
Maintenant, nous procédons. Maintenant, nous allons au remplacement total de l'articulation. Avant de... People are speaking in the background. I'm really lost whenever people are speaking at the same time, so can't translate word. OK. Pour procéder maintenant, ce qui concerne le remplacement total de l'articulation. Avant d'y arriver, nous allons devoir parler de l'objectif même de ces remplacements de l'articulation, du remplacement total. Yes, please.
So first goal is to relieve pain, to improve the quality of life, and to maintain and improve the knee function. That's the goal. Now, once we see these goals, this could be from the surgeon's point of view, this could be from the patient point of view. So from surgeon point of view, we try to restore the alignment and to make the joint stable construct to increase the range of motion. That is our surgeon's perspective. From the patient perspective, they want ambulation, which is pain-free, early, and independent. But finally, what we are seeing as a functional outcome, that is the restoration of motion and ultimately patient going back to their respective functional area. So everything having similar destination. Okay, it's only our point of view from the surgeons or from the patient's point of view. It may be different, but ultimately we are our goal is only one. Here, functional outcome.
Comme on l'a dit, voilà le but de remplacement total de l'articulation. Premièrement, c'est de pouvoir atténuer les douleurs. Deuxièmement, de pouvoir garantir la bonne qualité de vie. Et le dernier but, c'est de pouvoir maintenir ou améliorer le fonctionnement du genou. Mais maintenant, quand on veut passer à ces remplacements de l'articulation, il y a deux points de vue. Le point de vue du chirurgien et le point de vue du patient ou du malade. Le point de vue des patients, c'est de pouvoir restaurer, c'est-à-dire faire les réalignements des articulations et encore de stabiliser la jointure. Et le point de vue du patient peut être de pouvoir ne plus souffrir, c'est-à-dire avoir, devenir indépendant en quelque sorte, c'est-à-dire se passer de douleurs, marcher, ne plus avoir ces problèmes. Mais en gros, que ce soit le point de vue du patient ou le point de vue du chirurgien, nous en arrivons toujours à la conclusion fonctionnelle qui est de pouvoir restaurer la motion dans le nid, c'est-à-dire le mouvement, la bonne articulation dans le genou du patient pour qu'il puisse être en mesure de vaquer à ses responsabilités habituelles. Yes, please.
Okay. So once we are clear of our goal, let me tell you what are the kind of joints which are amenable to replace in our body. So the one of most common joint which is replaced is the hip joint. There are different kind of hip joint. We'll see the example. Second is the knee joint. In our geographical location, the ratio is 1:1. Okay. Now the next joint is shoulder joint, which is replaced, followed by elbow joint, finger joints, very less cases of rheumatoid arthritis, and the list is ankle joint. In our geographical location, ankle replacement is not available. That was available in the past, but that was star ankle replacement, which was not very patient friendly. Outcomes were not good, so that was withdrawn from our location. So mainly it's a
Uh,
hip joint, knee joint, shoulder joint, elbow joint, which constitute 95% of the replacements.
Maintenant, nous allons voir les quelques types de remplacement des articulations. Nous avons l'articulation de remplacement de la hanche. Par exemple, nous allons voir la procédure d'indication. Nous avons le remplacement de genou. Nous avons le remplacement de l'épaule. Nous avons le remplacement encore de doigt. Euh, le moins utilisé dans ce qui représente 95% de possibilités, c'est-à-dire ce qui se fait généralement 95%, ce sont les trois premiers. Le remplacement de la hanche, le remplacement du genou, le remplacement de l'épaule, euh, du coude également. Et le reste, là, c'est un peu, ça représente le moins de pourcentage possible. Ça ne se fait pas, ça se fait un tout petit peu rarement. Les deux derniers que l'on a cités, le dernier point noir. Yes, please.
So what is the implant of this joint replacement? So mainly it's a metal, cobalt, chromium, nickel, which is the most commonly uh, available. Nowadays, titanium is the most superior one which is available. In addition, we have gold coated implants which are available in patients who are allergic to cobalt and chromium. Like if you see some patient wearing the artificial jewelries which contains the cobalt or chromium and develop these allergies. So these kind of patients, uh, we uh, we give gold plated implant as a choice. That is called the gold knee in case of here. And there is one more material which is oxenium, which is also like black colored implants which are available.
Hum, so, c'est quoi ce que nous appelons les implants, le matériel des implants que l'on utilise? Les implants sont utilisés pour remplacement des articulations. Ce n'est rien d'autre que le plastique accompagné d'une dose de médicaments qui aide à régler les problèmes d'arthrose et autres. Et pour ça, il y a de ces patients qui sont allergiques peut-être à d'autres types d'implants qui sont céramiques, ainsi de suite. Maintenant, euh, on propose un autre type d'implant qu'on va devoir développer ici. May you please come back with the implants for those that are allergic because I lost it.
Okay. So cobalt or chromium like material, some patients are allergic. So we use gold instead of cobalt and chromium.
Gold.
Gold.
Euh, ok. Comme je le disais tantôt, il y a des implants qui sont sur base de cobalt, cobalt à chromium, dont d'autres patients, c'est-à-dire malades, présentent des allergies, on y va avec l'or, c'est-à-dire en base de l'or, pour pouvoir les aider pour aider spécialement ceux-là qui sont allergiques. Yes, please.
Okay. So this was the implant. And one more thing which audience needs to know is in case of hip, there is a bearing surface. Like one is the implant and other is where the movements occur. That is called the bearing surface. So in that we have plastics and ceramics and metal.
Pour ce qui concerne les implants, il y a une chose que l'on doit savoir, c'est que nous devons se connaître, c'est que les implants peuvent être en métal ou encore en plastique ou en céramique. Yes,
Okay.
please.
So we'll show in on the X-rays. Now patient selection criteria. Uh, Earlier, once like implants were not very developed in those era, the age criteria was only the higher age group, say more than 60, more than 65 years of age was the indication for surgery. But nowadays, what happens with the improvement of these implants, as well as the from the patient also demand. Imagine a patient of 25 years of age having full-fledged arthritis, not able to move. He or she cannot wait till he become or she becomes 65 years of age, that is next 40 years, for getting the knees or hip replaced. So they need early treatment, pain-free period they need for their professional life, though their personal life. So nowadays, age is not indication. Any age after 18 years of age is the indications.
OK. Et pour la sélection, les critères de sélection des patients qui peuvent être éligibles à ces remplacements d'articulation. Auparavant, c'était 65 ans et plus. Ces derniers temps, il n'y a plus d'indication puisque on peut avoir des gens qui sont beaucoup plus jeunes, qui seraient endommagés et qui auraient des problèmes là qui pourraient d'ailleurs le mettre en difficulté avec leur profession, et ainsi de suite. Donc, il n'y a plus assez d'indications à part ceux-là qui sont âgés de plus de 85 ans. You said for those, there's an indication for those of 85 plus.
85 plus, yes, it's a now chronological age. So first is minimum age, that is should be above 18 years of age once the growth has happened. Upper age limit is based on the patient medical condition. If patient is 100 years of age and patient is fit for surgery, then he or she can undergo surgery.
OK. Cela dépend de la condition physique de la personne. Voilà. Comme on le disait tantôt, ça dépend de la condition physique de la personne. Si une personne est âgée de plus de 8 ans, de plus de 8 ans, ils peuvent déjà procéder à cela, à condition qu'il soit physiquement fort. Il n'y a pas vraiment de chronologie à suivre. Yes, please.
So another thing needs to understand in the overview of joint replacement is the complication and risks which is involved. So let me tell you the overall worldwide, the the success has improved very much if done in the well indicated condition and well indicated planned and executed surgery. So worldwide, its a complication rate is less than 1%, and that includes number one, like infection, implant loosening, which could be due to infection or aseptic loosening, or in case of hip, there may be chances of dislocation, but these are less than 1%.
Euh, c'est ce qu'il faut encore avoir en tête, sont les complications et les risques qui sont en vue. Euh, pour éviter ces risques-là, il faudrait que la chirurgie soit bien exécutée suivant le plan qui a été donné, euh, suivant le timing qui a été donné également, puisque si l'on ne suit pas le planning, on risque de tomber dans ces hauts risques-là de complications. Mais si c'est très bien exécuté, le risque potentiel est de moins d'1%. Ces risques sont liés peut-être à quel problème de... Can you come again with the risks, like the
So,
loosening and stuff like that?
so one is infection, another is
Okay,
loosening because of either
okay,
infection that is called septic loosening or without infection that is aseptic loosening, which comes with a like many years after the surgery, aseptic loosening.
okay.
And
Les risques que l'on... Yes, please.
in case of hip, there is additional complication which is a dislocation.
OK. Pour ce qui concerne les risques, l'on a cité les infections après la chirurgie qui font à ce que il y ait des complications, que les implants puissent céder. Du côté de la hanche, pour ce qui concerne la chirurgie de la hanche, il y a beaucoup plus généralement la dislocation de, de la hanche. Donc, c'est un peu ça. On parle de infections qui peuvent causer des complications après la chirurgie. On parle encore de la dislocation de la hanche. Yes, please.
Okay. So other could be anesthesia related complications or something which can happen anyway, like fractures. Okay. So coming to surgical techniques and how we, since we have limited time, we'll discuss the main points which audience needs to know. So surgeries are either conventional, the time tested one. Other is using the technology. Okay. Small incision or using the navigations and computers. Okay.
Donc, comme on l'a dit, d'autres problèmes liés à ces complications peuvent être les fractures. Oui. Et pouvons en venir maintenant à quelques chirurgies techniques. Oui. Il y a de chirurgies qui peuvent être conventionnelles, il y a des chirurgies qui sont faites à l'aide de la technologie, il y a des incisions et il y a des chirurgies qui sont accompagnées par la machine, donc par le moniteur, oui.
Okay. So
Yes, please.
let's take the example of knee joint. Okay, I'm just taking now example knee joint. So conventional we use jigs and we see the mechanical axis with the eye with what we have been trained, the anatomy, we take the landmarks, and then we execute the cuts and implant. Okay. Like this one is done by the conventional one. So you can see here the gross deformity and other thing also been corrected. It's totally straight knee. This is by conventional. Okay.
Euh,
And
euh, pour, pour les traitements conventionnels, vous pouvez voir les exemples qui sont donnés. Ils visent beaucoup plus au réalignement, à l'alignement des articulations qui peuvent être endommagées. Et cela se fait d'une manière conventionnelle, ça peut être simple, ça peut être pour des cas simples ainsi que des cas complexes. Yes, please.
okay. So here also you can see the outcome very, very nice. No problem with that. Now, since the evolution of this technology and AI, we have started using the computer and there are different generations of computer we are using. Like here you can see we implant the sensors with the jig and other thing, and we calculate the how much measurement we need to cut and how much angle we need to keep, so it improves the accuracy. Okay.
You were breaking, like, okay.
Okay.
Le-
Okay. So am I audible now?
Yeah, you are audible. At the end,
So we
just
use
the end that you were breaking.
we use computer for accuracy of implantation. Okay, as you can see here.
Yeah. Pour ce qui concerne l'autre type de traitement qui est assisté par la machine, l'ordinateur, c'est euh, le, pour être beaucoup plus précis, pour la précision. Donc, ça nous indique euh, la masse que l'on doit retirer, la masse d'os que l'on doit retirer avec beaucoup plus de précision. Yes, please. Comme vous pouvez voir dans des photos ici.
So latest being the robotic arm which we use. So these robotic arms help us in cutting accurately. Okay, to improve the accuracy. Here you can
Pour
see.
et vous pouvez voir, on utilise aussi la main robotique qui nous aide à faire des scissions avec beaucoup plus de précision.
Okay, so conventional works also very good. Navigation, computer, and robotic all works very good. So these are the example where we use in case of very difficult knees or redo surgeries, they have more value.
Donc, voilà un peu le des traitements que l'on propose, traitement conventionnel.
Yeah, Mr. Jonathan.
Are you on call, Jonathan? Uh, I think, doctor, we can continue. Some issue with his network, I think.
Okay, okay, no issues. So these difficult cases are very nice indications for improved AI technology or navigation and robotics. Okay, so what the literature says, let's just skip this. So outcome. If you see all the parameters, range of motion, functional assessment, implants type, everything, both conventional and as well as the newer one works very well. Only one way where it beats the conventional one is accuracy, the degree of accuracy. Okay, where the newer technology being the superior one. Okay, so there's medias also some there is a um, the things they advertise more of a robotic and other things, but um, let me tell the audience that the outcome, the long-term outcome is the similar one. It has not been proven superior over the conventional one. So, Mr. Jonathan, I think you are back.
Yeah, I'm here. I'm here. Can you hear me?
Yes, we can hear you, and I was just telling the truth about this newer technology, high expensive technology things. So short term, mid term, maybe some different, but long term outcome, their survival is almost similar. So adding cost, adding cost does not uh, give much more value than the conventional one. So we can conclude here that the conventional as well the newer age having almost similar functional outcome, which we discussed as our goal. But if you see the accuracy of implantation on X-ray, there is a superiority in case of navigation and robotic.
Ok, comme on le disait tantôt, il faut dire la vérité, c'est que ces chirurgies sont beaucoup plus chères, mais la chirurgie est presque la même, tant du côté conventionnel que du côté assisté par la machine, l'ordinateur ou encore par la main robotique. Mais le plus efficace serait, on recommanderait peut-être la main robotique pour beaucoup plus de précision dans la chirurgie,
So,
bien que le résultat soit presque le même. Yes, please.
so Jonathan, in I think in the last session of this webinar, let me show some X-rays and some types of joint replacement so that the audience will get the how it looks and on the X-rays. Okay, so these are typical. our intraoperative or theater look like. So coming to just 111 cases, like here, if you see the fracture dislocation here in the shoulder, so shoulder replacement in this case is the answer. And as you can see, shoulder is replaced. It could be hemi, it could be total shoulder replacement. And in case a rotator cuff is disease, we do a reverse total shoulder replacement. So here you can see all the pictures. Okay. Okay. So coming to elbow. Elbow, very selective indications for elbow replacement, especially in case of severe osteoarthritis, either in case of rheumatoid or fracture dislocation, which is not salvageable for fixation. We recommend total elbow replacement and it gives pain-free period. The survival is not as great as knee and hip, but certainly whatever time, say 10 years, 15 years, it works, it gives a pain-free period. Okay. So coming to knee, as I have shown there, it's a simple primary varus deformity. You can see both knees replaced in the single seatings. So these are the complex where patient is either high BMI status. So Jonathan, come back and here I'm showing some examples. So here it's a complex total knee replacement in high BMI status where the weight is say BMI is more than 35 or 40. Okay, so we augment with the rods, intramedullary rods, just to reduce the stress over the joints. Okay, either bone is weak or weight is more. So in that case, we augment. So these are called complex total knee replacement. Okay.
Donc, l'exemple 6, 6O, vous nous montre un peu un aperçu, donne un peu un aperçu de différents types d'arthrose, encore plus de chirurgie que l'on peut faire. Le premier, c'était la chirurgie de remplacement et de réalignement. Ici, vous voyez, c'est complètement différent. Le remplacement complet des articulations euh, qui sont complexes.
So there could be like complex bilateral knee if patient in high risk case, like in this case, high risk patients, we have achieved. And the good thing about the joint replacement is is getting the functional outcome. Patient is mobile and their medical conditions also impressed. Like here, the lady is showing in their app how much she walked, which was not possible without these complex cases. So this is more complex where the augmentation is done in both the femur and the tibia, and this joint is constraint joint. Okay. In case of bone loss, we need to give sleeve also as ROMs. So in case of, as I mentioned, fracture can happen in as in normal way in knee replacement. So that can be either fixed or replaced in complex ways, like here we have done. Okay. So here, like you can see, it has been replaced with the more complex variety of knee replacement. Mr. Jonathan. Okay. As here we have done with the very complex uh, knee replace where the fracture has been fixed earlier and it was not amenable for saving it. We have replaced with the more complex form of this is the highest form of joint replacement. Okay. In case of hip, if you see, there are different kinds of permutation and combinations which are available. Hemi, total, in total, it's a metal on metal, ceramic on ceramic, ceramic on high cross poly, ceramic on with the metal, and there are different permutation combination of bearing surface as well as different types of implant, cemented, uncemented, hybrid, reverse hybrid. Okay. And one more kind of complex stems are also available. This is restorative stems, mid-modularity, where there was a fracture which was also fixed and replacement also done. So this kind of ASROMs and Wagner systems are also available. These are complex form of total hip replacements. Here you can see there is a bone loss which is being grafted first. Impaction bone grafting is done. Above that, total hip replacement is done. So these are very, very complex cases. Okay. Here you can see the dysplastic hip, which has been replaced in both sides very accurately. Here also you can see the sickle cell anemia and other patient which been hip is replaced with uncemented one.
Oui,
So this is more example of using the
les images,
navigation, very, very accurate placement in both AP and lateral view. Yeah, Mr. Janat.
les images, les images
So
suivantes vous
these are,
donnent
so these are,
un
I was just telling, so I was just giving the example of different kinds of joint replacements and the complexity which may be involved, complex total hip replacements. Okay, like here also you can see the complexity where the acetabulum has been also uh, repaired in addition to the total hip replacement. So these are very complex cases. So one more complex could be arthritis or tumor where we resect and we replace the joint. Like in this case, chondrosarcoma of the proximal femur, we have operated with the mega processes. This mega processes is a kind of special joint replacement where the large bone is resected with the soft tissues and other making it very unstable. So these are highest form of joint replacements, mega processes. Like in case of hip, you can see, in case of knee, you can see this is a case of Ewing sarcoma, proximal tibia, which is being operated with the mega processes. Okay. So at this point of time, we can take some questions or any queries. Mr. Jonathan, we need you. Dhruva,
Hey, doctor. Can we start with the question?
yes, we can take some questions.
Right. So I think we have two questions in chat and we have some question through doctors who have asked us in past.
Okay.
So
So,
let me share my screen and I'll share the questions with you.
sure. So where I can see those questions?
Give me a sec. Uh, yeah. So can you share the screen now? Can you see the screen? I have shared my screen.
Yes. Yes.
Yes. So we have first question from Dr. Hivat, Dhirje. He wanted to understand, I think, the treatment of knee osteoarthritis.
Okay. So I have in this slide itself, I have given um, treatment, non-invasive, minimal invasive, and invasive, depending on the stage of arthritis. So right from pharmacological therapy to the physiotherapy to the injections, I had given in those slides. They can assess or they can WhatsApp us.
Sure. So I think what doctor is trying to say is that he has suggested the diagnosis part and the symptoms part. If you feel anything, then please reach out to Jivo and we'll help you to reach out to Dr. Dr. Jha, so that he can help you further on every case. Right, doctor?
Yes, and for them, just I have uh, like I'm just sharing the slide which where I have mentioned the holistic therapy. Okay,
Right.
here they can see non-pharmacological, pharmacological, as well as the injections and the surgical part, the three kinds of surgery. Okay.
Understood. So, moving on to next question. It's by Dr. Thimsegen Nisigwe. He wanted to understand the approach to assessing late life disabilities.
So assessment can be what I presume he wants to assess how much disability is there and how this we can plan for treatment. So disability can be assessed with there are different scoring system which are available. Okay. And clinically, these are done clinically, clinical detailed evaluation, and that is focused on how much pain the patient having and how much restrictions of activities patient having. So patient having a very high disability is a candidate for total joint replacement.
All right. Moving on to next question. Next question is by Dr. Zimu. He wanted to understand what is the durability of the replaced joint and maybe the affordability or the price range in a directional sense, since they so that they can compare it with other countries with respect
Okay.
to.
So durability of joints certainly depend on the patient condition also. Like I said, something which was simple and something which was complex. So in simple case scenario, nowadays the durability is very very good. Say more than 20 years or more than 25 years of age. But certainly there are some range. Some may last for 40, 45 years also. Some may last for 15 years also. So on average, it's 20, 25 years in simple cases. In case of resurgeries or redo surgeries or complex cases, the durability is reduced. And about the prices. So prices you can share with them. We have a wonderful rate which is very competitive, and in Indian market because of the implants are cheaper and the surgical price is also cheaper. So it's almost one third of the price of the developed nation.
Sure, fair. Moving on to the next question. We have next question by Dr. Nakhausa. He wanted to understand what complications for the patient wearing an external fixator.
Okay. So see, action fixator is for some temporary measures, and very, very rarely it could be for definitive treatment. So once it's a temporary thing, so you can understand there could be complication because of fracture, that is like non-union, which is the most commonly seen, or malunion, where the fracture heals in bad shape. And the most common complications which are seen are the pin tract infection because it communicates from the exterior environment. So at the junction of these axial fixator with the skin, patient develops infection and osteomyelitis. So that is the one of commonest complication.
Got it. Then we have another question by Dr. Emibuddin Salim. He wanted to ask that he has a fracture in his left ankle since he was 14-year-old. Uh, Parental negligence. What is the orthopedic treatment like
So
suggestion from your end?
what I presume that it's a post-traumatic ankle arthritis, which is sustained earlier. So they can share the access with us. The most easier way and the most durable form of treatment in this case are ankle arthrodosis. Okay, that
Right.
relieves the pain and makes joint stable.
Got it. Then there are also some questions in chat. If any doctor directly wants to ask a question, I think this is the time. Else we can start uh, checking questions from the chat. So I think we had first question from Dr. Ogumbe. So Jonathan, I have translated the question. He has asked the question in French. Can you please ask Dr. Ogumbe to ask the question if he's on call? Jonathan? Jonathan, are you on call? I think Jonathan is not on call. So I think for the broader group, I'll ask you the question, Dr. Jha, and then we later translate it to French and share it with the relevant doctor. He want to understand in which case can we proceed with joint infiltration and what are the consequences of joint infiltration with uh, corticosteroids.
Corticosteroids. So, see, all joints are amenable for infiltration. We need to understand the purpose why we are doing the infiltration. Like in case of osteoarthritis, severe osteoarthritis, patient is not fit for surgery. In those patients, it could be for pain relief. In some patients who are not willing to be operated in few months or years coming time, so we need to give a temporary relief for those patients. That is, they are buying time so that in future they can be replaced. So this period to make them pain free, we infiltrate. So everything comes with some cost. As I mentioned, the four class of infiltration. One is the PRP, that is the platelet-rich plasma. Second is the stem cells. One is the viscoelastic supplemented, that is the hyaluronic acid. So this having a very different purpose. Platelets and stem cells focuses on healing, so late relief in pain. Viscoelastic supplementation gives early pain relief, but it's very temporary. Maybe it's 6 months, maybe 1 year. Out of that, corticosteroid is anti-inflammatory. It's kind of a substitution of the oral medication NSAIDs you are giving into the joint. It gives wonderful pain relief. Okay. But problem is the thing that patient doesn't understand this pain-free period, what to do. They think themselves to be cured. So they started rebound activities, and that leads to the deterioration of the joint status. And they blame steroid as a cause. So as I mentioned, we should focus on the why we are giving the injections. Okay. So first thing is make it very clear. We are giving for pain relief. Patient should be consented for that. The one complication which could be seen in this kind of steroid infiltration is the chances of infection. So infection is the potential complication which may make the condition more deteriorating. So they may not be candidate for joint replacement in the future also.
Understood. Got it. So I'll ensure that we translate this answer for our doctor
Yes.
in French and then we'll
Sure.
communicate it to him. And if
Sure.
there are any questions, we'll take it with you separately.
Sure.
Then we have another question by Dr. Tempest Guinea Nisiguana. Doctor, if you're on call, can you please ask the same question yourself? Uh, Doctor, are you on call? I think I can
Uh,
see him on call. His question is, how can we check the compatibility of the implant materials? I think you would have mentioned in your presentation some implant materials where you use gold, where there were some reactions in the skin, right? So you wanted to
uh,
understand how can you check the compatibility of the implant materials?
so compatibility, usually we think it as a very inert one. We sometimes try to take allergy history from the patient. If patient is say allergic to many things, we try to extract from the history whether patient is allergic to artificial metals like cobalt, chromium, artificial jewelries, rings. So patient if allergic to those things, we presume it to be because of cobalt, chromium, molybdenum, other things. So we suggest them for gold coated, that is called gold TKRs.
Understood. So does it answer your question, doctor? Uh, if you can please unmute and just confirm. Dr. Tempesnini. I'm not sure if I'm pronouncing your name correctly, doctor.
Hello?
Yes, sir. Does it answer your question? Hi, doctor. You were speaking something. Dr. Nisagwene.
I said, I get him, so I understand.
All right. Thank you. So I think let's move on to the next question. We have another question in chat by Dr. Varela. Dr. Varela, if you could just share your question about the case which you are mentioning around the patient. Dr. Varela, are you on call?
Member of WYC Cliffy. I'm interested to be a member of WY Cliffy. She has written. So I am not sure what is this. So
So I think, no, I'm talking about some question which is on top further. I think there's a question by Dr. Varela. He has mentioned that he has a case where the patient complained about an implant. The patient experienced an excessive amount of untold discomfort. So how can we determine the compatibility of implant material or what to do next?
so first thing they one must assume it to be implant to be inert one. We should look for the known complications, and out of the most common which I mentioned is the infections and the aseptic loosening. We should look on those aspects first before blaming the material to be non-compatible. Okay, so allergies are very very rare. That should not be coming to first as a differential diagnosis. If patient is feeling discomfort after the surgery, so it could be the malpositioning because of wrong implantation, or it because of some other subclinical infections. So we must first rule out those things first before blaming the compatibility issues. That's my suggestion.
Got it. Does it answer your question, Dr. Vesela? Do you have any follow-up questions? I think it's your time if you want to unmute and ask doctor himself. All right, fair enough. Moving on to the next question. Then we have another question in chat by Dr. Atenda Salomon. Doctor, do you want to ask the question yourself? You have posted 3, 4 questions. Dr. Atenda, are you on call, doctor? Dr. Solomon.
Good
Yes.
afternoon.
Right.
Good afternoon. Thank you very much for the wonderful presentation, sir. Based on the presentation, I have some few questions to ask here. Number one is based on the KL grading system. I want to know the gold standard. Is it the
So it's
presence
not
of? I want to know the
okay.
gold standard of the diagnosis
So
based on
gold
the
standard.
KL grading system. Yes, the gold standard of
Yes.
diagnosis based
No, no,
on
no, no.
KL grading.
So KL is just WHO classification of osteoarthritis. It's not very good, but what happens? Diagnosis is
Yeah, I
the
just want.
clinical. Diagnosis is the clinical one. We must understand patients complaining of the typical pain, pain while walking, or pain while taking stairs, or pain while sitting cross legs. There's a definitive tenderness on the joint line. That's almost confirmatory for osteoarthritis. Number one, that's the gold standard clinical diagnosis. Now we need something to to having a baseline test. So X-ray is being the baseline test, out of which there are different kinds of classification system has been given. So this is very, very good question, which I want to elaborate. That X-ray is not the criteria for deciding which patient to undergo surgery. Example, grade 4 of KL, arthritis, may not be candidate for joint replacement. If patient is having minimal pain and treated very well with the physical therapy, he or she may not be the candidate for knee replacement. In contrast, grade 3 patient could be a candidate for replacement. If patient has been tried all conservative measure and pain is not relieved, patient is a candidate for joint replacement. So in that way, it's a paradox. So it's not the gold standard. Yeah, yeah, Dr. Solomon.
Okay, thank you so much, sir. I'm talking about based on the S-tray, based on the S-tray, is it the presence of the osteophytes or the absence of joint space or both? Can we use grading? That's my question, sir.
Okay, so in case of osteophytes, it's a location of osteophyte which matters more. If say it's in around the weight bearing area, or like what we call kissing lesions. Okay, so it's very very relevant, and it may be amenable for the minimally invasive surgeries like arthroscopy and other things also. But for me, it's a typical joint space reduction. Okay, because
Okay.
indirectly it shows the articular cartilage is gone. It's gone. Okay, and it's irreversible. So that is more important.
Hmm. Okay, sir. Okay, sir. Okay, sir. Thank you so much, sir. So my second question out of the four is that how effective is the medical therapy? And I want to know the role of steroids in the treatment of the early stage of osteoarthritis.
So medical therapy is the first line of treatment. Okay,
Okay, sir.
so first it should be tried, and once like if pain is not relieved with all this medical therapy, with physical therapy, and patient having the difficulty in activities of daily life, what we call ADL, if it is disturbed, then patient is
Okay.
candidate for surgery.
Okay, sir. Okay, sir. All right. Thank you so much, sir. The third question is that I want to know the success rates of replacement therapy in terms of the biocompatibility and durability. What is the success rate, sir?
So success rate, if you say the uh, survivalship of these implants, newer implants, is supposed to be, I'm taking as a average value. It's more than 20-25 years. But certainly there is some range. And it's what I call it's a two-way. Once we say success, once we measure success, there should be some prerequisite to measure those success. That means we presume that patient has taken care of the joint. Okay. The precautions which we had been told. Okay. And the physical therapies and the exercises which has been told, if we presume that this has been taken care of, so the value I have mentioned is the average. Okay.
Okay, sir. Thank you so much, sir. My last question is on the third one, and this is based on the patient's point of view, sir. So
Okay.
a patient wants to know that what is the frequency of the review? Being the implant is supposed to be an artificial thing. So they want to know what is the frequency of review. That is, will the implant be permanent there or it will be reviewed, accordingly based on the particular time. So how often do we review the implant, sir?
You mean the follow-ups, no? Follow-ups by radiological means.
Yes, sir. And they want to know, will the implant still be removed or to be permanent in the patient's body?
So first thing, it's a permanent irreversible procedure. Okay. So it doesn't needs to be removed. Second, the follow-ups are like first milestone is the 2 weeks where we want to remove the stitches. Then it's a 6 weeks post-surgery where all the that is removed. Then
Okay.
it's a 3 months, 6 months, and then annual.
Oh, that's fine. That's good. Thank you very much, sir. I appreciate it, sir.
Thank you.
Yes.
All right, so we have some more questions. So, doctor, if you have some time, then we can.
Yeah. I have time. Please continue.
All right. So, then we have one question from Dr. Farouk no Nobre. Dr. Farouk Nobre, if you want to ask your question himself.
Okay.
Dr. Farouk,
Yes.
uh, if you can ask the
Hello.
question
Yes.
yourself from
Are you
Dr.
hearing me?
Jha.
Yeah.
Yes, Dr. Farouk.
I wanted to know which kind of cares we must have for the patients if this patient is an athlete. For example, if the patient needs to have made a hip replacement, which cares he must take after the surgery? Which special cares?
So I understood your question, and it's very tricky questions because, see, in athletic, the demand of the activities is much more than the normal population, like the jumping, the contact sports. So what happens in the coming time, since a artificial joint, as I mentioned in the previous question also, there is some wear and tear which is involved. Okay. Usually we tell the patients not to jump, not to run, in for the sake of longevity of the implant. The more you do the activities, the more the wear and the more the chances of re-surgery, that is the revision surgery. So in general, as a dictum, we tell these patients. But as you mentioned, the patient is athlete. So first thing we need to tell them to change the activity level if possible. If it's not possible, then there are some certain variation of implants which are available. Let me put the slide which I had skipped here. So here,
Dr. Jha, your screen is not shared.
okay. I'd share a type of implants there, hip replacement. I'm not able to change it right now, but there is like one slide, yes. Uh, 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 yes. So here you can see
So, Dr. Jha, we
the
can't.
best.
Sorry.
Yes.
Can you please share your screen again?
So it's there. No.
No, 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 no. Since
Oh,
I was sharing the screen for questions, I think it got cancelled. So can you share your screen again, please?
okay. I'm trying. I'm trying. So I don't find, but it's a
There'll be a
slide.
green button on the bottom which is share on your Zoom call, and then you can select the presentation.
I presume that no. I think that was earlier, but if they have this slide 61, so here I have shared some pictures of that metal to metal and femoral head which is resurfacing. There's the X-rays also in the corner. Let me see the share button again if it's possible.
Yes,
Okay. Okay. Can you see my screen? No.
uh, no, doctor.
Okay. So just go to the slide 61. You can share this. So this is doctor. This is like the special kind of implants which if it's mandatory for the athlete to continue their sporting activity can be offered resurfacing, resurfacing, or metal on metal. Okay.
No, let me share my screen, doctor. Can you now see my screen and the presentation, Dr. Jha?
Yeah.
Is is this slide 61 which you were mentioning?
No. Just go or down, down, more down, more. Yes, more. Yes. Yeah, here. Above this. Yes. You can share this slides.
Okay.
Okay. So can everyone see here?
Yes, doctor.
So
Yes.
here,
Yes, sir.
yes, you can see the
Yes,
special
sir.
kind of implant here that is called hip resurfacing. So it's a more favored in those athletes. Okay. And certainly those patients are not this ceramic kind of implant is not good for them because of a higher chance of breakage. Okay.
Does it answer your question, Dr. Narobi? Uh,
Yes, yes, yes. Thank you. Thank you for that.
then we have another question from Dr. Dennis. Dr. Dennis, if you can ask your question yourself.
Yeah, thank you very much for the presentation. Actually, at our center, we haven't get a case with complications of infection, but I was wondering if we get one, if should we remove the implant or should we keep on treating with antibiotics? That was one question. And the other question is, there is a case with implant and they wanted to do an MRI. And we were stuck because we said the radiologist there said we cannot do MRI because of the implant because it was a metal. Now I wonder if there is implants that MRI compatible. Those are my questions.
Okay. So coming to the first part of your question, that is the treatment of infection. So certainly we need to understand the kind of infection and the duration of infection. So in my view or by literature also, if it's acute one, be aggressive, be very aggressive. Antibiotic won't suffice. Just don't hesitate to go inside and clean the joint. Clean the joint first. Okay, that is multiple debridement. Still, you feel it's a clean from inside. Antibiotic can work as an adjuvant, so it's not the primary therapy. So just go if you feel the infection is coming from the deep. Just go inside. In case of knee, you can change the poly also, polyethylene component also. Put drain for 3 to 5 days, give antibiotic, okay, and come out. But if it's very long standing, so like its presentation is more than 1 month, so may we need to do the stage revision surgery. That is a stage one where we put remove the implant and put the antibiotic spacer, followed by 6 weeks, monitor with the ESR, CRP, CBC, infective marker within normal limits, skin has healed, go for the stage two. That is the revision total replacement. That was the first part. So in early, be aggressive. In second part, non just change to the stage surgery. Okay. Now coming to second part, you have mentioned that I just forgot. First was infection and second was,
Uh,
doctor, can you repeat second part?
It was about MRI compatible
Okay.
implants.
Okay.
MRI.
Very good question. Very good questions. And many times a radiologist or this technician exploit this kind of things. So first, let me tell you, all joint replacements we can do MRI for that location as well as any other part of location, provided only one condition. That is, the implant should be well fixed. Say, for example, if patient has sustained fracture of those implant and implant is unstable, okay, or you have put the screws nearby that and that is loose. So in that scenario, MRI may not be good idea. But if you feel the joint is stable, MRI can be done for that part as well as other part also. Now coming to that part, if you want, say you have replaced the hip and you want MRI of hip replace. So we need to change the the coils for the MRI, and we want that implant specific MRIs where the artifact of implant is neutralized. Okay, I
Thank you
hope.
very much. And
Yes, yes.
So I think now we will have time only for one question. So any doctor, I can see three, four doctors asking more questions. Anyone who wants to ask one final question from Dr. Jha can take the stage and ask the question. Uh, Dr. Eliza, do you want to ask the question?
I'm just interrupting here. One question, very interesting question has been asked in chat box by Ebenezer Nai Adu Saike. So he has asked, can you explain 90% rule for the hip replacement surgery? Certainly, this is a different question actually. I would like to take because this is not commonly asked. We teach a lot of postgraduate, we train a lot of. Certainly, it's not in text, but this is a common perception actually. In first 6 to 8 weeks, we don't want patient to bend beyond 90 degrees. Okay, talking about the hip replacements. So that is to reduce the chances of dislocations so that the capsules heals very well. So I think that's a 90% rule for the hip replacement. Okay. Okay.
Got it. Thank you. And I think one more question from a doctor where Dr. Elisa, where she has an art knee joint replacement problem herself from 2018. If you could suggest her some suggestions.
So our knee joint, I think a range of motion patient is doctor is mentioning with limited joint movement due to car. Now, can we replace to allow? Certainly, it can, but only the thing is the nature of the implanted material changes from the simple to the complex or maybe the constraint type. Okay, so constraint type of joint replacement is usually recommended in case of post-traumatic conditions.
All right, I think thank you, Dr. Jha, for taking out your time today. And thank you, everyone, for joining this webinar. Uh, for everyone else, we have a regular webinar series where multiple specialists from different hospital comes every weekend, and then they try to help you, educate you about some specialities or some things around their specialities. So if you are interested to be part of more such events, please reach out to your Jivo POC in your WhatsApp group, and we'll add you to the Jivo Training Academy through which we have started this initiative. So thank you, Dr. Jha, for taking out your time and have a good evening.
Thank you. Thank you very much.
Thank you, everyone.